Yeah. I need Michelle to get up here.
I'd say go ahead.
I'm about to. Okay. Like to call the House Health Committee to order. Will the clerk please take the roll?
Representatives Bain, Boyd, Capley, Carringer, Clemens, Faison, Farmer, Gillespie, Hakeem, Hawk, Haynes, Hemmer, Hicks of Hawkins, Hicks of Washington, Hill, Jernigan, Kumar, Martin, Mitchell, Rudder, Sherrill, Travis, Vaughn, Whitson, Williams, Vice Chairman Leatherwood, Chairman Terry.
Here.
Chairman, you have a quorum.
All right. Thank you and appreciate.
I'm honored. I get to sit by
Yeah. Appreciate everybody for making it this way to hearing room 3. As most people know, we have a little bit of a bill going on over in House Hearing Room 1, and so we have been relocated. Do any of the members have any personal orders? I do. Okay. Representative
No, I
Carringer?
guess I just wanted to thank everybody for being patient with us that did make it over here.
All right, thank you. So, personal order, our committee intern, Charles Lolis, it is his birthday today. So wish him happy birthday. Thank you. And so what we're going to do, we do have a calendar, but because some of our members are in the Education Committee right now hearing another bill, we cannot vote on any bills at this time, but we do have a budget presentation that we can hear. We have Commissioner Alvarado and the Department of Health will be presenting their budget. And so what our plan will be is for them to present their budget and take questions. And then at the end of that, we are going to recess and then check on the status and see if we have any other members, if they're finished over in House Hearing Room 1. If we can get those members back over here, then we will take up our calendar. If they are not finished around that time, then we will likely roll every bill on this calendar to next week. So without objection, we will go out of session and bring up the Department of Health. Thank you, and appreciate you being with us today, and look forward to hearing what you have to say.
Thank you, Mr. Chairman. Thank you, members of the committee. Let me first introduce my staff. We've got several of our staff members here. I've got Dr. Toby Amison, who's one of our deputy commissioners, Deputy Commissioner John Webb as well. Mary Catherine Bratton, who's general counsel. J.W. Randolph, deputy commissioner. Holt Whitman, if you know him, a legislative liaison. We had also Dr. Tim Jones. There he is, Dr. Jones, our CMO also. So proud to be here this morning and happy to present. I think since the last time I've met you all, I've had a chance to go across the entire state. I think we visited all 95 counties, gone to every health department, every regional office. A lot of very committed people within the Department of Health who are working to improve health every day. The one thing I come back to, and I mention a lot of times to my staff, we focus on rankings. I know we're a state that's very proud of our rankings, proud of our basketball rankings, football. We're proud of our economic rankings, fiscal rankings. People are moving to Tennessee in droves. But one ranking that's not good is our overall public health rankings. We're ranked 44th and 42nd overall when it comes to for people that are getting older. And so we're trying to work all the time on that. And I remind our staff that as we work with other departments, sometimes as other parts of government improve, often health can improve as well. And so we're working towards that. Thought we'd start with our the budget. We thought we'd go over, first of all, our cost increases for the upcoming year. So To start off, I'll just dive right in and go one by one on this list. Our first cost increase is year 3 of 5 of the Smile Tennessee pilot project. This is $18.1 million in non-recurring state funds. This proposal requests the third year of scheduled funding. It directs $12.8 million to higher education institutions to provide continued support of expanded dental classes and the creation of remote clinics to improve rural outreach. In addition, $5.3 million in funds to support prosthodontic programs, dental programs for seniors, recruitment incentives, and clinic expansions. I'll cover a bit more details about where we're at with our dental project later on in the presentation. Cost increase number 2 is the Educational Dental Safety Net Care Pilot. This is year 3 of 3. In conjunction with the Healthy Smiles Initiative, this funding continues the department's partnership with Lincoln Memorial University to expand access to dental care in underserved areas in East Tennessee. Specifically, LMU utilizes this funding to expand dental class sizes and create education sites to offer comprehensive dental care for underserved patients in 33 counties in East Tennessee. Item number 3 is the Rural Healthcare Resiliency Program. This is $50 million in non-recurring funds. This comes from TennCare Shared Savings. And the Rural Healthcare Resiliency Program will target improvements in healthcare facilities and the delivery of healthcare services in rural and underserved areas. Through a competitive process, this program will provide grants to organizations and direct care providers to expand facility capacity and implement innovations to the delivery of integrated, higher quality, comprehensive prevention healthcare services. Currently, the department manages a similar ARPA-funded program of over $250 million. I'll talk about that again a little bit later on. But during that competitive grant process, the department received over $400 million in applications, showing a significant demand statewide. So the proposed $50 million in funding would allow the department to offer a funding opportunity for organizations that maybe didn't participate in the federally funded program or have other innovative ideas moving forward. Now, as you all know, rural Tennesseans experience significant challenges in accessing resources to support behavioral and physical health needs. And these challenges include the lack of adequate healthcare facilities in rural areas and shortages of qualified healthcare providers. Often, rural communities experience distinct social and environmental obstacles, including mental health challenges, obesity, and substance misuse. In 2022, Governor Lee convened the Rural Health Task Force to provide insight on the best ways to address the unique health challenges in rural communities. It comprised of 34 individual stakeholders. The task force included members from public, private organizations, state agencies, and the General Assembly. And the task force worked to develop practical recommendations for high-impact investments to improve rural communities' access to preventive and comprehensive healthcare services, promote equitable, efficient, and effective healthcare delivery, and to improve health outcomes for rural Tennesseans. Cost increases 4, 5, 6, 7, and 8 are all based on the recommendations of the task force to improve access to care and the development of a workforce serving the health-related needs of rural Tennesseans. Also, item number 1 was also recommended to be continued as part of those task force findings as well. So cost increase number 4, and all of these are basically TennCare Shared Savings, 4 through 8. Number 4 is $1 million in non-recurring funds. Generally, access to care in rural communities is a significant challenge, and there's great variability in the specific challenges individual communities face to offer core health services to citizens. And over the past few years, there have been several innovative care delivery models developed to help bridge the gaps in services in these communities. However, rural communities and service providers often lack the resources needed to evaluate and implement these innovative service delivery models. So recognizing these challenges, the task force recommended through a public-private partnership the establishment of a Center of Excellence, or COE, and this COE would provide an array of technical support services to rural areas to tailor healthcare access solutions that address the specific challenges faced by local communities. Item number 5 also has to do with the COE with grants, and as that works with rural communities, the COE would have instances where overcoming some healthcare access challenges may require additional planning and support beyond the in-house capabilities of the COE. And additional funding might be needed to support local transition efforts. So to supplement those efforts, the task force recommended $1.4 million dedicated to the establishment of 2 grant programs for planning and implementation related to COE recommendations to local communities. Item number 6 is also for rural healthcare training programs. A key component on improving access to healthcare services in rural areas is improving the pipeline of providers supporting underserved communities. And studies indicate that rural rotation exposure in training or residency is positively associated with choosing rural practice. However, barriers include the lack of medical education programs and minimal training opportunities and facilities in rural areas. So to assist in overcoming these barriers, the task force recommended the establishment of additional training opportunities, including funding for preceptorships, rotations, fellowships, and training tracks, and residencies in rural areas. Preceptors provide students with vital clinical education, which trains the next generation of healthcare professionals, and programs like rotations, fellowships, and residencies can increase trainees' exposure to rural lifestyle and medical practice to improve in-state retention rates for providers. I'm the product in Kentucky of one of those. I did my residency in a rural area, and I stuck around for 28 years. Item number 7 is rural specialty care. So to improve specialist access in rural areas, the task force recommended $800,000 to create an e-consult platform for primary providers in rural locations to consult with specialists to improve the delivery of patient care. The e-consult platform will include real-time one-on-one e-consults between rural primary care providers and specialists to seek clinical guidance and expertise, improve access to specialty care in geographically isolated communities, and avoid unessential referrals. And additionally, the task force also recommended the implementation of a specialist incentive pilot for the department's Project Access program, which leverages nonprofit entities across the state to coordinate with local Tennessee Medical Association chapters and connect uninsured patients with healthcare services. Specifically, the task force recommended allocating $250,000 to incentivize additional high-speed specialty providers to deliver in-person services in rural communities. Item number 8 is a little under $67,000. This funding request supports the implementation of a one-year pilot designed to expand telemedicine offerings in rural areas, and it would be conducted in 6 sites comprised of 3 safety net clinics and 3 community-based sites. Maybe like a library or something along those lines, also to improve access to telemedicine and healthcare services in rural communities. Item number 9 is now kind of outside of the task force. This is more of a laboratory career expenses. The State Public Health Laboratory is subject to continuous review and accreditation by federal agencies. These reviews ensure that the state lab is meeting both federal and industry guidelines. The most recent CLIA survey indicated deficiencies in temperature monitoring of samples during transport. This is a finding for which the state lab has implemented a short-term solution, but the department's intent is to use this recurring funding to upgrade these courier services to ensure that our temperature control is the long-term resolution to this issue. And then item number 10 is a proposal that establishes 2 part-time positions for the Tennessee Pharmacy Board as intended by Public Chapter 457 of 2023. No additional funds were needed as the part-time positions will be supported by existing dedicated funding. Now, as we go through all the requests, we often want to talk a little bit about some of our reductions, and so we thought we'd cover a couple of these. Effective September the 1st of 2023, the federal government reduced direct funding to the Overdose Response Coordination Office Program, otherwise known as ORCO. And this funding supported grants to local governments and organizations for services to reduce incidents of opioid overdoses through community-based programs targeting high-risk populations. As a result of these federal changes, the department has reduced contracts and absorbed personnel costs to meet the current federal funding levels. Although the federal government reduced direct funding to the ORCO program, direct funding to local governments and other organizations increased. And so the department doesn't really know if these increases offset the total loss of direct funding to the department. The reduction also represents that item number 2 is mainframe billing reduction. This represents the net savings to the health-related boards due to the transition of board applications from the mainframe computer to other modern platforms. That totals $173,000. So then I thought I'd talk about some of the things I mentioned earlier and some of the successes we're having and some updates on some of the programs that we've got. I know there's quite a few funding and people are often curious where we're at on some of these. The first part is the healthcare safety net. And a kind of a key tenet of this administration has been to expand and improve access to healthcare for rural and underserved populations in Tennessee. In 2019, the healthcare safety net program received $8.4 million in recurring state dollars. Since that time, the administration and the General Assembly have increased recurring state funding for the program to $31.1 million. This nearly 400% increase in funding is a direct investment in improving the lives of some of the most vulnerable Tennesseans. This investment in state funding also expanded primary care and dental service offerings to 118 providers to uninsured Tennesseans through over 340,000 patient encounters. And the volume of patient encounters is important. However, the investment in the safety net is more than improving access to care. It's also about improving the care that individuals receive through the safety net program. In 2019, Project Access provided only care coordination services. After increased investment, Project Access now provides additional specialty care services through a network of volunteer physicians, hospitals, and clinics in 86 counties. In 2019, dental safety net providers only provided cleaning and extraction services. Through the increased investments, providers now offer restoration services, fillings, and diagnostics. And not only has the General Assembly's investment increased the patient volume of the safety net dental clinics, but it has also improved the services and support offered through these providers. And also reimbursement rates for primary care patients have increased from $20 per visit in 2019 to $68 per visit in 2023. Dental rates have gone up from $20 in 2019 to $102 per visit in 2023 as well. And the Safety Net Quality Improvement Incentive Program is also something that we've designed to improve service provision and increase access for uninsured adults seeking care in Safety Net clinics. Participating in that program results in a $20 per encounter bonus to providers, and it helps us kind of improve quality and monitor that for the patients that are receiving care through a lot of the Safety Net. The next item we've got here is the Healthy Smiles Initiative. In 2021, Tennessee ranked 45th in the country for the ratio of population to dentists. Nationally, there are about 60 dentists per 100,000 population, compared with only 46 dentists per 100,000 in Tennessee. Estimates indicated that the state would need over 700 additional dentists to meet the current practice standards. And right now, in dental health professional shortage areas, which are areas where we've got don't have enough dentists, over 2.3 million Tennesseans live in a dental HPSA. In fiscal years 2023 and 2024, nearly $28 million has been allocated to reduce barriers to dental care. We've dedicated $17.7 million of that to the expansion of dental class size at UT and at Meharry. We've also set aside $8 million to support expanded services, including prosthodontic services and dental services for senior citizens, and about $2 million is dedicated to provider recruitment incentives. Meharry has expanded its dental class size by 13 from 62 to 75. UT has expanded from 100 to 120 for dental class, and also UT has expanded its dental hygiene classes from 30 to 48. And the educational capacity has also increased by 16 faculty members between the two schools. Meharry has 4 additional, and UT has 12. Both schools have started working on rotations at our departments, at health departments and our clinic sites. Meharry's at Montgomery County, and with pending expansions in Smith, Putnam, Grundy, and Wilson counties. And UT currently provides services in several clinics in Davidson, Knox, Shelby, Madison, Hamilton, Sullivan, and Cumberland counties. And both are looking to expand rotations in areas that are underserved. In rural areas, I think Kingsport right now is funded in the FY25 request. Grant funding also assisted patients receive nearly 1,000 procedures in the prosthodontic program. Smile 65 Plus projects serving 3,481 senior citizens through 13,835 direct encounters, and nearly 1,000 people have received case management and navigation services to assist in scheduling appointments and receiving services. We've also got a loan repayment program that's launched in February to improve retention rates for dentists in Tennessee. Offers up to $300,000, $100,000 per year. That's the average loan requirement for dentists when they go through dental school. And we've actually reduced the number of vacancies we have because we've had even dentists from outside of our state come into our state for this program, which has been very good. The next topic we thought we'd talk about is ARPA funding overview and kind of where some of our funds have gone there. The first item we thought we'd talk about is the healthcare staffing assistance, which was $120 million. This proposal had set aside funding for hospital staffing assistance of $70 million and nursing home staffing assistance of $50 million. The hospital assistance portion of this project is complete now with an estimated total cost of about $65 million. The nursing home portion of this is still in process. The department's in the process of approving submitted reimbursements, and we've dispersed a little over $15.5 million to date. In the new state public health lab, as I mentioned earlier, this project replaces the current state lab that's located at the RS Gas Complex. The new building will be a facilities revolving fund facility, so DGS has taken the lead in shepherding this project through the capital process. And DGS has been excellent, really, with our staff and engaging with us through the design process to ensure that we receive maximum functionality for this investment. Right now, it's on schedule and it's within budget, which is always good news. Local health department infrastructure is another big thing. You may have talked to some of your local health department officials. This is $129 million. This is comprised of 2 major components. The first is the establishment of a grant program to local governments to build, renovate, and upgrade local health department facilities statewide. These grants were available to the 89 rural counties with the minimum project amount available of $450,000. This grant program requires a local match of the lesser between 25% of the total project costs or 10% of the local government's ARPA direct allocation, and 78 counties were participating with 76 executed contracts. The second part of this project was also dedicated to the construction of 1 new regional health office located in the South Central region. Funding for this portion was set at $17.5 million. We also have some of these monies going towards our regional forensic centers. The department's providing grants to support both Knox County at $20 million, Hamilton County at $10 million, and their governments for the construction of 2 new regional forensic centers. Contracts obligating funds to the counties have been executed, and the department is confident that full spending will occur for these projects with the ARPA timelines. And then also we have the Healthcare Resiliency Program that I mentioned earlier of $250 million. This program looks to expand physical hospital capacity and enhance care delivery at healthcare facilities statewide. The program has a capital section where healthcare facilities will competitively apply for grants to expand physical capacity. They have a 50-50 match on that. And the second part of the program deals with healthcare practice transformation. And although this program does not require a match, these funds will be dispersed in a similar manner as the capital grants program. It's a competitive process. Between both sets of funding, the department has allocated funds to support 93 projects statewide. 33 of those are capital and 60 are practice transformation. Like I said, we had a demand of $400 million of requests, but we were able to accommodate this, and we're hoping with the new requests that we have in this, we'll be able to fill some more of those ideas and concepts up. That's the presentation. I try to go as fast as I can, Mr. Chairman. I know everybody's kind of late in the day, but I thought I'd be open for any questions that you might have.
All right, thank you. Excellent presentation. And we're going to take a list for members that have questions. Representative Capley, I believe you had first on the list.
Thank you, Mr. Chairman. I just wanted to compliment you and your office, and our relationship in the past 2 years has been excellent. Y'all have been very accessible, and it's been a pleasure. So thank you for the work that you do.
Thank you, Representative. I appreciate that. I would argue I have the best staff in state government. I know people will argue with me on that, but I'm totally sincere when I say it. I work with these folks every day. I visit every health department and the commitment of the folks that are out there. So that goes a long way. We appreciate that. Thank you.
All right, thank you. Representative Hakeem, you are recognized.
Thank you, Mr. Chairman. Commissioner, could we go back to slide 2 and then to slide 1? And thank you for being here and sharing this with us.
Sure.
Slide, is that slide 2? There we go. That 2 million overdose response, are we saying that we're have that under control, that the problem we have, or the money is being reallocated from some other place? So what are we saying?
So again, what happened here was the federal government, it was money that they had allocated for this, that they've basically taken it back and they're using those funds. They've got, I think, a pot of money. They've been funding local governments. We know that they've increased local government funding, but they've cut this away. They've reduced direct funding to our program within state. So this is not a decision by us. It's the federal government coming in and saying we're taking this away. We know that they're shunting some of these funds to local governments, but perhaps to be more locally driven on some of these efforts. We don't know exactly how much and to which governments, but we do know that they've increased those amounts. But we have 7 full-time positions of folks within our department that were part of this. So we're trying to find other places for them to go. Clearly, we have a lot of work still to do. We have the Department of Mental Health and Substance Abuse who kind of takes the lead on this. But a lot of the efforts that we've worked on this, we had a kind of a program, our OD2A program, which these guys often manage as well. So that is a grant that we've got for substance use prevention, for data collection, surveillance, for overdoses that occur in our communities. But again, this funding went to provide some support for that. So it's not our decision. Unfortunately, it was from the federal government. I don't know if the commissioner, do you have anything else to add?
Just as a point of clarification, Representative Hakeem, the department did not do anything incorrectly to cause this reduction. This was simply a reallocation of federal resources by the federal government.
All right. Thank you for that. One
You're good.
All right. Thank slide 1. And where was that? Rural, I believe it was the rural healthcare training. And those dollars, I think it was something about a rotation and some other things. Is this the same people who are going, I'm gonna use the term, in a circle? And we're not increasing the number of people that we have going forward that we think we might have.
Yeah, so I think what they're trying to do here in, practicing in rural communities, it's tough sometimes. Our rural physicians, nurse practitioners, or providers that are out there are busy, right? They may be the only provider in the community. It's tough to see a lot of folks. And so it's tough for them to take time to often take on a student or take on a resident or someone to come in and rotate with them in their office. And so you try to find ways to incentivize that. Obviously, we don't have any state income tax. Other states like Georgia and Kentucky have proposed things of trying to offer tax breaks.
Man.
Yeah, no, I understand it's a bad word, but it's trying to offer tax breaks to accommodate this.
Okay.
This would offer stipends to pay these individuals to say, if you take a student on and get a resident to rotate through, they get a flavor for what a rural medical practice might be like. And so if they experience that, they see it, they appreciate it. There's a lot of advantages to it. And a lot of folks, once they experience that and they feel it, they like it, and they have a better chance of sticking around. I think the statistic that we've had nationally has been that if you do a residency program in a rural community, odds are, I think 80% of the time that person will practice within an 80-mile radius where they trained. Just because you establish your referral, habits, you establish connections, people get to know you. If they like you, you stick around and you practice there. So if we can get a lot of folks and develop programs for residencies in rural communities, it's a very complicated process with the federal government to get those approvals. But if you can offer the funding for it and have someone come through and get their training there, the odds of them sticking around is much, much higher. So the hope for this is to develop those programs for nurses, for therapists, for physicians, you name it. The more exposure they get, the better their chances of sticking around.
One brief, the telemedicine, uh, some of us who think that, it's God sent, and I know you said a pilot, but do we have any statistics on, I guess, what we've done thus far, or how it's coming along?
Well, I think we all know during the pandemic, it was crucial really to provide a lot of services. There are certain services you can provide easily. I think behavioral health is often something that's pretty straightforward and easy to be able to be done that way. There are some things that we can't do. You can't do an abdominal exam through a TV screen of any type. So, but this is going to establish a one-year pilot, but it's designed to kind of expand this into rural areas. We do a lot of these services right now through our health departments, and so a lot of this is just an opportunity to be able to connect people to specialists. So sometimes if you just need an opinion from a neurologist, and you might not have one in a small rural community, but you could find a way to, again, it's part of our e-consults also that you mentioned earlier as part of this. It'll all tie in together, but you could consult someone remotely, a neurologist. You might be able as a doctor say, hey, can you please have the patient do these things? And they can observe some of those findings. They can give recommendations on what to do. We're doing that right now through a program that's very successful called TCAPES, which is done for our pediatric population. I think Vanderbilt University. Dr. Amundsen is an expert. She probably can give you a lot more detail on it, but it really is an opportunity for a primary provider who might not feel comfortable handling a rather severe case, somebody with mental illness or behavioral issue, that they can contact a specialist at Vanderbilt and say, I've got this patient in my office. What should I do? They can provide recommendations, and you can implement treatment while you're waiting perhaps for a referral to get things taken care of. Dr. Amundsen, I don't know if you want to expand any on that.
Sure. So TCAPES stands for Tennessee Child and Adolescent Psychiatry Evaluation System. It's based out of Le Bonheur out in Memphis, started out in Shelby County with the intention of spreading it across the state. Right now, it's available to any pediatrician who wants to call during office hours. They can call and get expert psychiatric consultation services, with the intention being that with time, those pediatricians will gain the skills to be able to handle some of those more mild cases on their own. So freeing up the pipeline for the more severe cases to go to specialty psychiatric services.
Okay. Thank you, Mr. Chairman, and thank you, staff,
Thank you.
Commissioner and staff.
All right, Representative Hemmer, you're recognized.
Thank you, Mr. Chairman. Good to see you again, Commissioner. I want to let the committee know that we shared a fun day at the UT game last year, and he dished his Kentucky blue for some orange.
Hey, they
So
played Texas A&M, so
appreciate,
yes,
appreciate
yes.
that very much. Thank you. I was able to talk to your staff earlier this year about the different items funded that some of them mentioned here. I think numbers, I guess 4 through 8 in regards to the rural task force. I'd urge every member of the committee to read that. I thought it was a very, very well done report. But I was curious about the things that weren't funded in this, and if you could talk through the things, some of the recommendations in that maybe was requested in your budget that weren't funded that you think are still maybe worthy for discussion.
Well, it's a tough budget year. One of the things that I am interested in is looking at things like people that are aging. I still practice medicine and take care of a lot of folks that are older, obviously. So for me, the aging population is something. I know there's some legislative action being taken right now to try to combine TCAD with the Department of with DIDD, basically, and combine them both together.
Mm-hmm.
So I've been talking to Commissioner Turner really about a lot of ideas that we've got on how we can do things to enhance that. So at some point, we've created a 5-year roadmap. There's a lot of resources available for people as they're aging in the state of Tennessee. They just don't know how to access it sometimes. And so there's, I got some ideas, hopefully for the future, perhaps in a better budget year, to be able to find funding that can fund some of that 5-year plan to help people get tied into that. It'll help with food insecurity, transportation issues, sometimes the housing stuff that people need, and some of those kinds of things. We also are looking at, kind of creating specialists who, right now you have the Pat Summit Center, which is great. They can often handle folks that may need an evaluation, but the wait list is so long. And by the time that person gets there, often their disease states progress to the point where they can't get some of the more innovative treatments that we have available. So trying to expand those networks, help our providers, and then hopefully you have the Department of Health be a location where people can come in and if when they need to have, where do I go for resources? What happens if someone suddenly develops dementia? That we can help navigate that very complicated system to get people there. That's the biggest thing I think for the future, and we're hoping to come at some point in the future to ask for some funding. But we know it's a tough budget year.
Thank you. In regards to that and the aging, I know you were able to tour the PACE Center in Chattanooga earlier this year, and know we're talking about maybe expanding that here in the state, and want to know your thoughts on your visit to the PACE Center and what that may could provide in regards to your earlier comments around elderly.
Sure. Yeah. So the PACE Center was I think it's the only one in the state right now that we have, and I know it's present in other states, but it's a unique model in which they provide. It's kind of like imagine having a nursing home in a daycare setting, if you will. So instead of having to go to a nursing home where your loved one has to get checked in and then they kind of live there in the nursing home, if you could check them in the morning, have a doctor on site, have therapists on site, have all the resources a nursing home would do, and then in the afternoon or the evening you come and you get your loved one and they sleep at home. And so it's that kind of a model. I know a lot of the reimbursements are the biggest issue with that. And obviously we don't get to do a lot of work in that space, but a lot of it's trying to get reimbursements for those models to be available and be able to be populated throughout the state. It takes a lot of investment to start one of those up. And you have to have a lot of specialists, doctors on site, provide emergency services and a lot of those kinds of things. But a really neat model. They do great work for the folks that are out there. So, I'm not sure the opportunities for that will just depend on funding and reimbursements.
Chairman Carringer?
I just had a statement. I just want to say thank you and thank you for your staff. I mean, all you do, because everything centers around healthcare now, even more so. And so just appreciate what you all do, and we'll be looking to see that big orange and white tie the next time before our committee. So thank you.
Thank you, Representative. Thank you. Thank you for your kind words.
Chairman Hawk?
Thank you, Mr. Chairman. Commissioner Dr. Alvarado, thank you very much for the work that you've done. You certainly have hit the ground running in Tennessee, and we appreciate that. As we're looking at the slide you have on the screen right now, looking at some of the cost increases, I don't want it to be lost on this committee, and we noticed in the Finance Committee as well that these cost increases are largely from TennCare shared savings, where we are in a very unique situation in Tennessee where we are able to do some of these things because of our effective management of the program. Several of those, it has been asked before, indicated as pilots, and this may be a question for I just gave you a doctorate degree, Mr. Webb. Mr. Webb, and you may be a doctor, forgive me. So this may be a question, but are we at a point where we can feel comfortable calling these recurring funds, and what are the other potentials for recurring funds that we could see from TennCare shared savings? It may be a little bit beyond your purview because there could be other areas, but the ones we're looking at on the screen there, can we see those as recurring in the future?
Go ahead.
Thank you for the question, and I'm far from a doctor. Representative Hawk, the task force kind of laid out a 5-year plan for funding, and the TennCare shared savings is, I guess, the vehicle that the administration chose to fund the first year of it. And so I think because of the non-recurring nature of that, we're going to call it a pilot. But as we kind of proceed and go through the next, 2 year, I guess, next 2 years, 2 through 5, we'll have very similar requests coming forward, much like we've done the dental safety net, or the dental services pilot program. I had to read couldn't think of the name, but we've come before you asking for those year after year as non-recurring items, and I anticipate that's what we will do similarly with the healthcare task force.
I think of note is on the Center of Excellence and the grants. If you read the report, one of the recommendations from the task force was that those would form private partnerships where you can have other organizations, private organizations, help fund a Center of Excellence so that it doesn't become solely reliant on government funds, and hopefully can be self-sustaining moving forward in the future. But the entire report was based off of a 5-year kind of proposal for it. The first two, obviously the first item there is year 3 of 5, and I think we've had really good success. So far, when it comes to our dental services, we're pretty excited about where that is going. And number 2 is year 3 of 3 of that. And then the only one that's going to be recurring is number 9, which is the lab career expenses. That's something that we're going to have just to maintain proper temperature control with specimens. But everything else is a 5-year plan. Hopefully, if we get an improvement of care in rural communities, it might be something that could be a decision for the General Assembly if they want to continue that or not.
All right, next on our list is Chairman Gary Hicks.
All right. Thank you, Chairman. Before I begin with the commissioner, I do want to take a personal privilege if I could. I know I'm out of order, but I have my director of schools back there, also my boss, Mr. Edwin Jarnigan, if he'll wave and if you welcome him to the committee. And then with this slide up here, I've got kind of one comment, and I certainly want to hear your thoughts on this. But when you look up there right now at number 2, and that is LMU, and this is year 2 of 3, and to put this in perspective of what this is doing for Northeast Tennessee, 35,000 visits have come through this program right here at LMU and what it's doing. Now, I can't speak on number 1 up there with UT and Meharry. I know they've seen a lot too, but I don't know that they've seen the numbers that LMU are seeing. If you would like to comment further on that.
Sure. I don't know that I have the statistics with 35,000. I mean, I've visited LMU's facilities, beautiful facilities, I have to admit. And so I think the more the merrier when it comes to dental needs and dental work in the state. So as many as are willing and can do good work and provide quality work for our folks. The stories that come out of these programs for folks, we don't have videos or photos to show you here today, but if you want to put a smile on your own face, it's just to go to those areas where people are getting those services, people in our health departments who can't get services any other way. And we've got a lot of dentists who are coming in, and with the loan forgiveness program, which has been very successful, a lot of them come in, they take care of these folks, and they find, they kind of fill up that bucket in their soul of joy of why they did this to begin with. And the people are incredibly appreciative. They'd never be able to get that work done otherwise. And some of the transformative work that's being done on teeth is really remarkable. But I know LMU, like I said, I've had a chance. I had a boot on my foot from a torn muscle from pickleball. So it was very, very memorable going there to visit. But it was a beautiful location, and I know they're doing great work. So we're excited to have everybody who's chipping in, and we're hoping, again, to grow our dental workforce in the state.
Mr. Chairman. And my final question on slide number 6, dealing with the ARPA funds. So a couple questions and a couple of thoughts with this. Number 1, is there a deadline to have this money, $730 million? Is there a deadline to have it spent? And what is that deadline? And then as far as all these projects, are we going to meet the deadline to be able to spend the money? And just overall, how's the construction going?
Sure. I'll let Deputy Commissioner Webb.
Sure. Good question. The deadlines for at least obligating the funds will be the end of this calendar year. So we have to have everything obligated by December 31st, 2024. And from a departmental perspective, that typically means a grant out to a different organization. And we are well on pace to have those funds obligated by that deadline. Spending has to be completed by December 31st, 2026. And so we've got, a little bit of time, but probably not as much as we would like to spend all those funds. This is something that we think about constantly, about how we can best, expedite the construction, the bid, the procurement process, and still maintain compliance with federal law. We feel pretty good about the local health department piece of it. We think that we will have we'll have those funds spent. The majority of those projects will be renovations, which are not quite as intensive as new construction. The state lab construction will start this spring. General Services is confident that we will have that wrapped up long before the deadline. And then we have a South Central Regional Office that will be a capital expense as well, and that is well on pace to be fully expended before the deadline. The other large pot that we have are the health resiliency programs. Part of that, the capital pieces there, it's a 50-50 match. We feel good where we are right now. We've got, I think, all the contracts executed at this point, and we anticipate full expenditure. And then the other part is a practice transformation piece that's related to that. And that's not as capital, but those are smaller projects that we feel pretty good about. So I think we're on pace. And as we have underspending or we anticipate underspending, that's something that we will come to FSAG and the members of the General Assembly and let them know that we've got money to reallocate.
All right. Thank you very much.
I need to brag a little bit on John. He's kind of our money guy, obviously, and watches this very carefully. We know this is going to be an incredibly probably the most audited program in federal history, probably. Sure. And so he's very meticulous by making sure every I is dotted, every T is crossed. We're used to state monies. It's very easy to use state funds. The granting process is very easy, and most of our partners are used to that easy process. The federal one, it's always tons of strings attached, and so the paperwork is really onerous. And we've been trying to really help a lot of our local governments in helping them go through the process. But we're making sure we don't want to get stuck with this, being late and money's being called back and we're stuck with half-done projects. We're very conscious of that. We get a biweekly update from our staff about where our projects are at to make sure that things are on track. So we're very careful about that. We want to make sure we're responsible with it.
Thank you, Commissioner. Thank you, Mr. Chairman.
All right, thank you. Representative Bain, you're recognized.
Thank you, Mr. Chairman. Could you speak to the level of HIV funding and if that's being maintained across community centers in the state? Thank you.
Sure, thank you. So last year, as many of you may recall, we famously got a lot of attention about deciding to go with state funds, and you were all very kind to approve those state funds instead of using federal funds when it came to our HIV prevention. We have prevention, then we have treatments. People often confuse the two. Ryan White is our treatment side of it. There's always a constant need for that. We always are asking HRSA for more funds for the Ryan White program. We had a dip in that. Again, General Assembly was very kind to give us $10 million last year to fill in a bit of the hole that we had to maintain our treatment levels for the folks that are out there. But on prevention, we had a lot of funding. 8.8 was from the federal government. We only used 7 at our peak. And often it was just because the process was from a grantee to a sub-grantee to spending the money, waiting for the reimbursement, very onerous. We took $9 million and decided to bring that in-house. And I've got some numbers in the first 2 quarters in comparison from 2022 to 2023. So we take a look at how many, for example, the testing that we had in 2022 in the first 2 quarters, 17,000 tests that were performed for HIV with state funds because of how flexible it is. 37,000 tests have been done now for HIV testing. When it comes to, we have a couple of our partners, SEMPA and Nashville Cares, who have been doing work on PrEP and distribution of PrEP. They have an annual goal that they have on how many PrEP kits to get out. They've already, in the first 2 quarters, have exceeded their annual goal, and they're above it at 120%. SSP programs that have been out there that have done providing a vehicle that kind of helps a mobile SSP program in Shelby County, a lot of neat things that they've done. So what we've done is simplified the process. We said, our HIV numbers are going up. We've got to control this. Here's the grant, 3 pages, go out and do good work. And the community has responded. So we're very excited. And again, it's only 2 quarters worth of numbers. It's from July through the end of December. Hopeful that this will continue to go up. I suspect that it will, just because we've made it a lot easier for our partners to do their work. And so very hopeful for that. I consider it a bit of an indictment. I've talked to our national organization that helps represent state health officers to say, this is the kind of restrictions that we're getting. If we want to help certain populations and getting monies that they give us out, give us as much flexibility as possible. And all of you all know, probably if you go to NCSL or any organization like that, they're always advocating for federalism. This is true of red and blue states both, is if the federal government can give us the ability to use those funds more easily, we can get a lot more done because we know our communities. This is a case in point where we've taken state dollars and done over double the work that would have been done otherwise with federal funds just because of the restrictions. So I'm hopeful this will be a case study and something that other states can look to, and also to let our federal partners know, look at what we've done. Give us this kind of flexibility that can do better work and more work. Thank you for the question, though.
All right, Leader Hicks, you're recognized.
Thank you, Mr. Chairman. Thank you for being here, Commissioner, and appreciate your team being here. The question, we all know the numbers and the issues with the health of Tennesseans, okay? It's not real good. And we also know that Tennesseans are really struggling with mental health. So we had the opportunity to sit in on a meeting not long ago, sort of talking about merging these 2 things with integrated behavioral health. We met with folks from ETSU on that. Mm-hmm. And there was a lot of talking going on, but you didn't get to speak on that a whole lot. And I was wondering, is this something that you're familiar with? Is this something that has worked in other places that you've been? And I'd just love for you to give your opinion and speak on that a little bit, because we think it's sort of solving a big issue all at one time. A lot of folks that are struggling with health issues don't understand that they have a mental health issue. And a lot of people that has a mental health issue doesn't understand what effects that has on their health. So it's a good fix. So just speak on that a little bit.
Sure, thank you. So for those of you who don't know what that is, it's effectively, if you have imagine a primary care clinic, if you went to see your doctor for you name the medical condition, and you maybe had some mental health issues going on and needed counseling or someone to assist with that, to be able to say, hey, let me just have you go down the hall to see a mental health specialist inside of your office to take care of those needs. When you have clinics like a federally qualified health clinic, for example, or even rural health clinics where they get a global fee for the visit, they can embed and have wraparound services to address a lot of those things. And so they'll often get a reimbursement from the federal government that covers that and covers a lot of resources. They can do your diabetes education. They can see you for a primary care visit. They can do all kinds of things in that one visit that gets covered by that global fee. But if you don't have that designation, it's tougher. You need to have almost a separate reimbursement for that service. When I had a primary care clinic, there was a counselor I had in my office. This is 20 years ago. And his guy's name was Howie. He would come in and it was great. I had kids who needed issues. I had someone I could send down the hallway and he would do those. And he would see them monthly and tremendous results. People did really, really well. But the hard part was getting insurance to pay for those visits. They'd only cover so many per year. And it made it to where it was cost prohibitive. I couldn't afford him to keep those services up. And so a lot of clinics out there are asking for reimbursement for those services or to find some way to be able to reimburse for those. So the difficult part is always getting insurance to cover it. And a lot of the folks who need those services, it would benefit if you try to refer them somewhere. It's going to take you a long time to get someone in. If you have them right there and then you can address an issue that often can fix other medical problems. And so some of the stories you hear is someone whose diabetes is suddenly surging and they don't know why. And you try to counsel them on proper eating and, taking their insulin and doing everything else, but their mood is clearly depressed. They can send them down the hall, have someone see them and find out that they're having clinical depression. You treat the depression, suddenly they're more animated to take care of their other medical needs. So that's kind of the model. And a lot of it really is going to come down to funding for that model and trying to find a way to get insurance to pay for it. But it works. It makes sense. And we try to make things as easy as possible for folks when they come in. People want a one-stop shop if they can get it when it comes to healthcare. The easier you can make that, the better it is.
Thank you, Commissioner. Thank you for being here. Thank you, Chairman.
Thank you. And I think that brings us to the end of our list. And I had some questions for you, but we have such a great committee that they marked off all my questions as we're going through here. So would like to thank you for the work that you do and coming and presenting to us. And we always enjoy working with your staff and all our meetings, and they do a great job. And so again, thank you for coming.
Thank you, Mr. Chairman. Thank you, members of the committee. Appreciate your time.
All right, thank you. And so without objection, we will go back into session. We have received word from the clerk. We cannot take up bills while members are in another committee. And so what we're going to do is all the bills that are on the calendar today, we will take up first next week. And so we will, without objection, we will adjourn.